I want to begin the lectures with the most important aspect of trigeminal neuralgia, and that is the diagnosis. If you have the wrong diagnosis and do the perfect MVD, it will not work. And so everything hangs upon the diagnosis. And I am just delighted to introduce Stine Maarbjerg from Copenhagen, who is going to walk us through diagnosis and management guidelines in trigeminal neuralgia. Stine is going to zoom in from Copenhagen, I hope.
Hi, Chris. Yes, I'm in from Copenhagen, and I'll just share my screen. Looks like it's already shared. Please interrupt me if I'm wrong. Sorry. All right. Hello, everyone. I would also.
Stine, we cannot see your slides.
See my. No. Okay. Try again. All right. I think you can see it now. Okay. I am also honored to have been invited to speak to you today. Thank you for that. It's a very distinguished audience, and I'm becoming a neurologist, so we always think that neurosurgeons are really cool. So I'm happy to speak to you today. My background is that I've been doing research into trigeminal neuralgia for the past 10 years. I'm a postdoc at the Danish Headache Center at Glostrup Hospital outside Copenhagen, and I'm also specializing in neurology. So today I'm going to talk a bit about diagnosis and management guidelines of trigeminal neuralgia. And I have nothing to disclose. So this is usually the slide I start out by showing if there's an audience that doesn't really know about trigeminal neuralgia or how painful it can be. And I usually say that imagine that a kiss from a grandchild would evoke the most terrible pain you could ever imagine. And then people can somewhat understand and relate to that this disorder is really horrible to live with. But I know that you in the audience, you know about this. You have seen the patients, you have seen how much they suffer. And I think that what this does to us as physicians is that we really want to help. We want to do anything that we can possibly do to help. And then we treat with medication and surgery. But as Chris said, we need to really go back to the basics first and look at the diagnosis. Also look at the medication before surgery. So I'm gonna start out with this picture instead for you. What happens when microvascular decompression is unsuccessful? Well, in the neurology of clinic, we sometimes see these patients, and there are only a few of them. But when microvascular decompression is unsuccessful, we look in the hindsight and we contemplate a little bit about, was this the correct diagnosis? Did the patient try out the correct medical treatment before surgery? Did the patient get correct preoperative information on outcome and complications of microvascular decompression? This is something you really think about when surgery goes wrong, but it's obviously also important before surgery. Now, this patient, a 50-year-old woman, she did have trigeminal neuralgia, but she didn't get all the information on microvascular decompression before, and afterwards she didn't have any efficacy. She had a brainstem stroke, and then she also had this very rare phenomenon of a neuropathic itch. So you can see the whole second trigeminal branch is scratched out. So these are some of the issues that I'll address here about the correct diagnosis, correct medical treatment. So what I'd really like to stress also is that, yeah, with the fear of just stating the obvious or demanding something that is impossible, then I would suggest that trigeminal neuralgia treatment demands that you have a team across specialties dedicated to trigeminal neuralgia. You need neurology to ensure the correct diagnosis, information about the disease, and the correct medical treatment. You need a good neuroradiologist with the appropriate sequences, the appropriate interpretation, and you need a dedicated neurosurgical team for correct patient selection, information, surgical treatment, obviously. And going back to the diagnosis, I have brought the diagnostic criteria from the 3rd edition of the International Classification of Headache Disorders. These criteria are published by the International Headache Society. There are also trigeminal neuralgia criteria from the International Association for the Study of Pain. And these criteria lay the ground for the ICD diagnostic criteria, but the two sets of criteria are pretty much aligned. So they look very similar, and this was also, there was an effort done to have the criteria very similar. So let's look at the ICHD3 criteria. Trigeminal neuralgia is characterized by recurrent paroxysms of unilateral facial pain in the distribution of one or more of the divisions of the trigeminal nerve with no radiation beyond. And then the pain has to fulfill all of these criteria: short lasting, up to 2 minutes, severe intensity, a pain quality of being electric shock-like, shooting, stabbing, or sharp. And then this last criteria, or pain criteria, precipitated by innocuous sensory stimuli within the affected trigeminal distribution. What this means is that the pain has to be triggered in some way, either from a trigger zone or a trigger maneuver. And this was a new thing introduced with the 3rd edition of the classification, that it is mandatory that the pain is triggered. You can have spontaneous pain, but in addition, there has to also be some trigger factors or trigger maneuvers. And then this last criterion, not better accounted for by another ICHD3 diagnosis. Well, obviously, that's important, but I think that this should actually be expanded to another diagnosis that we know of, because there are so many differential diagnoses in trigeminal neuralgia. Moving on to the subclassification that is also common for the ICHD3 and for the IASP criteria. Sorry, the trigeminal neuralgia is subdivided into 3 subgroups: either idiopathic, classical, or secondary trigeminal neuralgia. And this is something new that was introduced as of 2018. So I'm just going to spend a couple of minutes on this. Classical trigeminal neuralgia signifies patients with an MRI with vascular compression with morphological changes of the trigeminal nerve, such as dislocation, distortion, atrophy, something that is different from the contralateral side. Now, idiopathic trigeminal neuralgia is pretty much everything else. That is patients without a neurovascular contact, or patients with just a contact where the blood vessel and the nerve comes into contact with each other, but without any morphological changes. And then the last subgroup, as you all know, secondary trigeminal neuralgia, it's not very common, 10 to 15% of patients, where you have an underlying disease such as a tumor or a multiple sclerosis. Then idiopathic and classical trigeminal neuralgia are further subclassified into subgroups based on the pain phenotype. Either you have purely paroxysmal pain, or you have paroxysmal pain with concomitant continuous pain. And here it's important to take notice of that in both of these pain subgroups, there is paroxysmal pain. You can't get the diagnosis of trigeminal neuralgia without triggered paroxysmal pain. But you can have that and then in addition have concomitant continuous pain. Now, moving on to the guidelines from the European Academy of Neurology. It was published in 2019 by a team of experts coming both from the International Headache Society and from the International Association for the Study of Pain. And I chose to highlight just a few points from these guidelines. First one, which drugs have shown efficacy in trigeminal neuralgia in the long term? With other words, which drugs do we have to consider before considering the patient medically refractory and then moving on to microvascular decompression, for example? So there's not a lot of new things in the guideline on this, but there is one new thing. So we state that carbamazepine continues to be the gold standard treatment, but it has a high failure rate of 50%, primarily because of side effects. Oxcarbazepine is probably as effective as carbamazepine, and it probably has fewer side effects. Second-line treatments are lamotrigine and gabapentin, either as monotherapy or as add-ons, but there is a low quality of scientific evidence. And then botulinum toxin type A, pregabalin, baclofen, and phenytoin may be used as add-on therapy, but again, a low quality of evidence. And what is new here is botulinum toxin type A is in the treatment guidelines now, and this is based on pretty weak evidence. So I hope that for the next guideline we'll have better evidence to see if it really works. I'm not convinced, but I'm willing to give it to. I hope that we can have a trial with it. Next point: when should surgery be offered in trigeminal neuralgia? Well, actually, the answer here is less clearer than the last guideline. Here we state that there is no evidence to indicate how many drugs should be tried out. There is a recommendation that medical management with adequate doses and regular monitoring is recommended before surgery. This is based on expert opinion. There is one study out there asking patients about if they consider the timing of surgery good. And here, a lot of patients answered that they would actually have preferred surgery earlier on than they actually had. And this has led us to recommend that patients should be informed of the possibility of surgery at an early stage. And this is the responsibility of the managing doctor, that's typically the neurologist. Now, finally, which surgical technique gives the longest pain-free period and the fewest complications? Well, the guideline states that microvascular decompression is preferred over gamma knife surgery in classical trigeminal neuralgia. Microvascular decompression may be preferential over radiofrequency thermocoagulation, balloon compression, internal neurolysis, and gristle in classical trigeminal neuralgia again. And then there is no preference for any one of the percutaneous neuroablative procedures in both classical and idiopathic trigeminal neuralgia. And then as something new, it is stated that there is no recommendation for the choice between any of the neuroablative procedures and microvascular decompression in idiopathic trigeminal neuralgia with a neurovascular contact. I think this is an important point because there has been some discussions about whether microvascular decompression should even be offered in patients with idiopathic trigeminal neuralgia with a neurovascular contact. Yeah, this was what I had brought with me for the sake of time. And I'm happy to take any questions, comments.
Thanks, Stine. We're just seeing if anyone has a question in the audience here. We do. What if there's no cutaneous trigger? Everything else is the classic, everything else is compatible, but they say, no, it comes spontaneously, it doesn't, I can't trigger it. Is that a good, strong indication that it is not trigeminal neuralgia?
It's a really difficult question, right? Because the diagnosis is purely history-based, and we don't have any gold standard diagnostic tool to be sure. In our own material, we have about 3 to 5% of patients who will state that they don't have any trigger factors or trigger maneuvers or anything. And then some would argue that they probably have some sensory stimuli traveling into the brainstem, and it's probably something they don't even notice. But that's not very useful for the patient. So I would say that I think I would call this trigeminal neuralgia if everything else fits and there's absolutely nothing else it could be. But according to the diagnostic criteria, you can't call it that if you're really like looking at them like very rigidly.
Thank you. I just want to add that they might not have touch-induced pain at certain times. Maybe the drug is working, maybe they're in a remission, but I always ask them historically, have you ever been able to, at any time, especially when it's bad, been able to trigger the nerve? Oh yeah, when it's bad, my God, I can't touch my face. Oh, okay, gotcha.
Yeah, exactly. It's actually also in the notes of the diagnostic criteria that you should try to evoke the pain. And I did not participate in writing these criteria. I think it's a little bit silly that you should try to touch a patient where the trigger zone is and see if you can evoke the pain, because I think the patient can easily tell you whether there is sensory evoked pain.
Dr. Burchell.
Kim Burchell here. Hi, good to see you again.
Hi.
Hi. So I'm a little surprised at the recommendation to do an MVD on what Mark Sandu would call grade 1 contact. That seems almost, I'm sure surgeons appreciate that, and I'm not sure anyone's ever done a study to look at the outcomes of that particular decompression, quote unquote. Many neurosurgeons will do something else to the nerve at the time if they're not completely convinced. So it seems like a little bit of a, acquiescence to surgeons to say that's because of your data shows grade 1 contact as really no relevance to the pathophysiology of trigeminal neuralgia. So maybe if you could respond to that.
Yeah. Well, I see your point, and you might be right, but there is just no scientific evidence supporting that microvascular decompression is not efficacious in this patient group. So most of the studies out there, they don't have this subgrouping about morphological changes or not. They just call it trigeminal neuralgia. So we don't really know, but we don't have any clear indications that it is not efficacious at all. And is it then just something else that the surgeon do while he's there? I don't know. I just think that I haven't seen any bit of evidence showing that it is without efficacy. Rather, it is up to 70 to 80% efficacy. And we all know that patients have microvascular decompression when they're completely at the end of the line. So it's, in some patients, it's suicide or surgery. So that's why I think we should keep the recommendation open, but do high quality studies into whether this actually is the correct recommendation, because I agree with you that maybe it is not correct. And maybe in the future, we'll have better imaging techniques, DTI, for example, so we can pick out exactly the patients with a simple neurovascular contact, but with DTI changes, and you could pick them out for MBD.
Stine, this is Ludwig Zrinzer. I'm a neurosurgeon from Queen Square. I don't know if you can see us, but I work with Manjit Matharu and Joe Zakharowska at Queen Square. I want to thank you for your 2015 brain paper, because I think that was a really good paper where you're looking at rates of neurovascular contact and symptomatic versus asymptomatic nerves in patients with trigeminal neuralgia. And even with simple contact, you are more likely to have a symptomatic nerve than an asymptomatic nerve, although it was much more likely if you had morphological changes. So I do think that there's a pathophysiological mechanism behind why simple MVD might work, contrary to what has just been said by Kim. On the other hand, I recognize that the outcomes of simple vascular contact are not as good as vascular contact that causes morphological changes. And therefore, I do rough up the nerve when I have simple contact, and I don't rough up the nerve when I have morphological changes. So I think Kim's point is very valid, that I think a lot of surgeons that say they've done an MVD on a simple contact without morphological change have actually done more than just an MVD, and have done an MVD with some form of neurolysis. So just to add to what has been said, or finalize what has been said, I think we have to classify the imaging and the findings at surgery very carefully, and we need a study as to whether a simple MVD or an MVD plus roughing up the nerve is what's required in simple contact.
Yeah, I completely agree with you, and I think this point about roughing up the nerve, it's not something that is in the scientific literature. Probably it has been done in most of the procedures, but it's not described.
Hi, Stine. Ray Sakula from the US. I wonder if you could comment on why neurologists in Europe look more favorably upon microvascular decompression than US neurologists. I think Kim and Ahmed can probably testify that the neurology community in the US has not embraced microvascular decompression. Any thoughts?
Hi, Ray. No, I don't have any very good thoughts. I discovered this too when I visited neurologists at UCLA some 10 years ago, and they were just highly skeptic. I don't know. You tell me. We in our clinic we have about 800 patients with trigeminal neuralgia, and we have a very close collaboration with our neurosurgeons. We have no problem with microvascular decompression. I don't know why this is the case. It has crossed my mind more than one time. What is the placebo effect here? If we had a sham procedure for MVD, what would you then find? I mean, the placebo effect in invasive or in IV medical treatments can be up to 40-50%, and this closes in on the efficacy of microvascular decompression in idiopathic trigeminal neuralgia. So that might be one point.
Hi, I'm Joachim Kraus from Germany. Thank you very much for your lecture. I'm still struggling with the concept of idiopathic versus classical trigeminal neuralgia, and I think it has not been clarified if this is a priori approach or a post hoc approach. And what I want to say is, for example, if you don't see a clear contact in the MR scan, but you find a compressing vessel at surgery, so this patient would be classified as idiopathic, but actually it's classical. And I think it would be nice to approach this issue in future definitions.
Well, you're right, and this is on me because I simplified the text, and in the diagnostic criteria in the full text, it says that it is morphological changes that are either seen on MRI or during surgery. So you could change the diagnosis per-operatively. Yeah. And if I could comment on this new subgrouping on idiopathic and classical trigeminal neuralgia, I'm not sure that this is a classification that is going to hold for the future. I think in the future we'll have much more refined tools using MRI to subgroup the patients. I think that some patients that are now termed idiopathic are not idiopathic. So I think it's just it's not a very good term to use for these patients.
Stine, it's Moja Hodai here. Thanks for your talk. I wanted to talk about, in follow-up with Joachim's point, about the evidence of arachnoidal adhesions that sometimes, actually most of the times, is not apparent on MRI. And it may look as if the contact or the proximity of the vessel and the nerve is minor, and then you look at it under microscope and you see these tiny but very firm bands that are holding the nerve tight. We're just not able to visualize them on conventional imaging. So I would offer that if everything holds, and even if the neurovascular compression appears trivial, that those patients deserve a microvascular decompression for good treatment.
Yeah, thank you for that point. Yeah, I agree with you that the evidence does not speak against your point.
Thank you, Stine. The
Thanks.
next lecture is, oh, sorry, go ahead.
Oh, sorry, there is a question on the chat about the adequate doses from Japan. There's a question on, is there any evidence that blood concentration monitoring is meaningful? And I'd just like to answer that is
Please
not
do.
meaningful.
Yeah. Sure, last question.
Not relevant. So thank you.